Welcome, everybody. It's Dr. T here. Welcome to our Q&A session. And tonight we have the amazing Dr. Sunita, now I've got to get this surname right, Chelvanayagam. Chelvanayagam. We just call her Dr. Sunita or Dr. S.
Or Dr. Chelva. You can shorten it.
Dr. Chelva. Dr. Chelva. We have Dr. Sunita with us tonight, who is one of our specialist women's health GPs. And she has had an extraordinary journey to where she is today as a women's health GP. And I am not going to do it any justice. So I'm just going to hand over to Dr. Sunita to tell us a little bit about herself. Welcome.
Thank you, Tamara. Thank you so much. So a little bit about myself. I grew up in Perth and I was schooled locally. I was really lucky enough to leave Perth and study medicine in Dublin in Ireland for 6 years. And that was a pretty amazing experience for a little Perthite. But I returned home to find my mum, who was also a GP. She was diagnosed with terminal ovarian cancer. So just finished medicine, started being an intern, and that was quite difficult. And initially at this stage, after doing my initial years in the hospital, I thought I wanted to be a surgeon, but I realized that this didn't really fit into a family and a balanced career. And so I trained in general practice, and I've really loved the breadth and scope of cradle to grave medicine, really. I mean, it's very, very rewarding getting to know people, their families, and following them through. Particularly, I've found my passion in and interest lies in women's health medicine. My own journey has actually influenced my interests, really. I mean, I found myself a mum of two little girls trying to juggle my life as a GP, and my husband was working overseas, and I was experiencing profound fatigue, depression, weird bleeding, pain, and it was, symptoms consistent with perimenopausal sort of symptoms. And I found that I was going into early menopause, and I was 38, and a lot of people would have just put that down to, well, you're just a young mother, you're busy, you're working. And if it wasn't for my own GP and eventually my gynecologist who validated my symptoms, I really feel like I wouldn't be where I am today. And so I feel so many women put their health last when, their place in their family and society is so important. So they really should be putting it first. So I really understand, Tamara, and empathise the demands on women. I sort of feel juggling professions and children's and partners and family and friends. I mean, you feel like you're being pulled in every direction, really. You try and keep it together. We're all under pressure to excel in every area. And I really find it satisfying to be able to help women achieve some sort of balance in their lives and prioritise their health. I think women have pretty amazingly dynamic bodies, and it's such a pleasure to look after women at every stage as they transition from adolescence to thinking about a family, to menopause and beyond that. And I feel very excited and blessed to be working at WOOM, because I always dreamt of a place that was a centre purely for women's health needs, and it materialised when you created it. It's really fantastic to be in this central location in West Perth, where women can come in their lunch break on their way to work, and they can have their needs met there.
Oh yeah, so I want to talk about that just in a little bit, but gosh, you've had that lived experience, which I think is incredible, and I think is so valuable when you can absolutely sympathise with so much of what a woman is going through. But something you and I have often talked about is your passion for really helping adolescent and young adult women to navigate puberty and development and into sort of their early reproductive life. Do you want to talk a little bit more to that passion, Sunita?
Yeah, I mean, I have two girls myself, and I have one who's about to embark on that journey of adolescence. And I mean, I can understand it's a very emotional and difficult time for a girl. And I mean, thinking back to our teenage years, we weren't even privy to very much. It's what we sort of heard about. Maybe we heard about at school or at home. And now girls have so much information accessible to them on the internet. And I mean, obviously social media can be a good thing, but it can also create a great amount of anxiety. It's really important for us, I believe, as health professionals to counterbalance this sort of emotive misinformation that's out there, because that drives so much anxiety of what I see, sitting in patient chairs. So it's something that I really want to get the dialogue right with younger people from the beginning and educate them correctly. I think that's really, really important going forward.
Yeah, I agree with you. Getting them using the right terminology, getting them to refer to their bodies respectfully, referring to each other respectfully about their bodies, it is so key when managing adolescent girls. And there's so many aspects to that sort of journey through adolescence, through puberty. Their physical development, their mental development. Dealing with periods and all the different ways they can manage that now. Often negotiating that space with mum, which is often really uncomfortable for young girls to be navigating.
Bring out a very interesting dynamic. Depends on mum's experience. It depends on their experience, their expectations. It can be a make or break time, really, in a relationship.
Yeah, totally.
With the family.
Well, we've talked about that before. Our own experiences of learning about reproductive health at school, and how we were traumatized, and hoping that our girls going through adolescence are not going to be traumatized as well.
That's so true.
So something else that I know that you are quite passionate about is the education of women around contraception, because it's such a big field, and like you've alluded to, there is so much trash out there on the internet and amongst sort of social groups. And it's really down to you guys, down to us to really educate young women and their mamas on what's right and what's wrong about contraception. So tell us about that.
Well, I mean, it's, as you said, it's a massive topic. And I mean, most women would probably lament the fact that we're in 2021 and we still haven't come up with a male contraceptive. But we have so much available to us. So at least there's choice. And I guess in Australia, we have quite a few, we have many, many combined oral contraceptive pills available to us. We have the progesterone-only pill, the vaginal ring or Nuva ring, depot injection Implanon. We have hormonal IUDs, the Mirena and the Kylena. We have non-hormonal copper IUDs. And there's so much mixed information about all of these things. I mean, it's meant that a lot of Australian women and girls have ended up having unwanted pregnancies. I mean, they have untreated period difficulties, which mean that they have time off school and work, and or PCOS untreated, because they're just too scared of the potential side effects of all of these entities. So I was just going to talk through some of them, I guess, and some of the common myths that are around. I mean, the combined oral contraceptive pill is still the most common form of contraceptive in Australia, and it's probably about 28 to 30% of women, I think, use it. And when we're referring to combined pill, it means the estrogen and progesterone pill, as opposed to the mini pill, which is just the progesterone only. There's so many myths and misconceptions about it. And so it's, there's a hesitancy for doctors to prescribe it, and there's hesitancy for the adolescent population particularly to take it, because they listen to what their friends are doing. It's something, we don't just prescribe for contraception either. When I'm talking about contraceptives, it's actually something that we use medically for menstrual cycle irregularities, painful periods, acne. I mean, it can help reduce the incidence of iron deficiency, anemia. And, clinicians are really beginning to realise that endometriosis is present in teenagers, so they need treatment and relief early. I mean, the pill's been around since the 1960s, so it's 50 years of experience we've had, and research is available to us worldwide. And it's very, very effective if you want it to be. Can be 93 to 99% effective. And we know that women can get side effects from the pill. We're not saying that it's a one-size-fit-all solution, but, women, yes, they can get nausea, they can get headaches, they can get breast tenderness and spotting and water retention and bloating and melasma, which is a reversible pigmentation of skin. Weight gain is a big one that women talk about, and it hasn't actually been proven in studies, and it varies from woman to woman. Maybe the most that's been found, maybe anecdotally, is 0.5 kilo to 1 kilo, but perhaps that's due to water retention. Weight gain as an entity is multifactorial, and age and stress and external factors are often at play. But as women, we love to blame the medication that we're on rather than our lifestyle. I think age, naturally, weight and metabolism will change. The most common reason that I would see discontinuation of the pill is probably the effect on mood and libido. And it's very difficult to predict. It hasn't directly been shown to cause depression in studies, but there's a lot of anecdotal evidence around, and we can't really ignore it. So I'd certainly say to women, talk to your GP about it if they feel this is the case.
Yeah, can I just jump in there, Sunita?
Yeah.
I often, because there are sort of 20 plus different types of pills that are out there, yeah. I'll often have that suck it and see kind of chat with a young woman about, look, I don't know which of these side effects you may or may not experience, and you're nothing like your friends, so you just sometimes have to suck it and see.
You do. And scientifically, I think they can't show a big difference in the side effects, really, but that's the beauty of human beings. There's individual variation, so that is part of it. And so sometimes you do have to persist. And look, a lot of women, we forget, actually feel better mood-wise on the pill. Some, love the fact they get much less periods, their skin's awesome. So, it can be very beneficial. One of the main side effects that people worry about, and it's very, it's in the public at the moment, is the relationship of blood clots, and the pill. And it's true. I mean, there's definitely a risk of clotting with the pill. It's something that we've known about for a long time. It's much more apparent when they had the very high dose nasty pills in the 1960s. But since then, the levels of estrogen are much lower, and there's many more advanced types of progesterone as well. And I mean, I was just looking at the risks. I mean, to let people know that the background risk of women who are not on the pill is about 4 in 10,000. And so this might increase to 7 to 10 in 10,000 when you're on the pill. But we can't forget that in pregnancy, that climbs to 20 to 30 women per 10,000. So, with all the other risks of pregnancy as well. And of course, like we said, there's always other factors at play, like age and smoking, obesity. There's lots of inherited clotting tendencies that women don't know about. We don't like to prescribe it to women who have classical migraines, and that means a kind of migraine where you might be losing vision or you have some sort of neurological feature, because it does put women at risk of strokes. And we perhaps don't prescribe it to women who are approaching their 50s either. There's also a lot of international controversy about 4th generation pills. I think there was a few big cases in the US about Yaz and Yasmin and Valette causing even more tendency to clotting. But I think in reality, it's only a very small percentage of risk. The other thing that I'm sure you experience as well, women worry about breast cancer risk because it's a very topical issue. And while we know that it marginally increases the risk of breast cancer, it's after 5 years of use. And again, there's lots of other factors. So age and genetic, environmental, lifestyle factors. And we don't know, I think, if it's a direct cause. I think if a woman does develop breast cancer on the pill, it's not a worse outcome than someone who wasn't on the pill. And we don't talk about the fact that it is actually protective for ovarian, endometrial, and bowel cancer. There's a few other little myth-busting things about the pill I wanted to throw out there as well. Just that the pill doesn't reduce your future fertility. It's very, very reversible. That's why we're so particular about compliance, because you can ovulate if you miss a pill. It's very reversible. Adolescents and young girls can start it, as soon as they've had an established period, and they can stay on it around until the age of 50, as long as their risks are very low and they stay in close contact with their doctor and are being monitored. There's sort of a myth that you need to have a break and give your body a break from the pill, but there's no physiological reason to do that. It's possibly more disruptive to your contraception if you keep chopping and changing anyway. And there's also there's no reason that women can't take their pill continuously. I mean, if you don't want to have a breakthrough bleed, sometimes it can be very beneficial for pain, bleeding, premenstrual migraine. So it's a very safe thing to use.
Yeah, I'll just jump in there. I do have some patients who are so debilitated by their periods, taking, up to a week off work or school.
Absolutely.
that we just say, do you know what, just have a withdrawal bleed on your holiday. Yep. So some of them will only have a withdrawal bleed twice a year. Is it harmful to their health? No.
No, yeah, correct me if I'm wrong, but I don't think there's any harm in that. There's no need for your own cycle to come through at all. I mean, there is that truth that women previously were pregnant and breastfeeding for most of their lives, and we actually have far too many periods now, even though people think the converse is true. So, I mean, yeah, the reality is that the pill's not for everybody. And so what else is out there? I guess what's becoming a lot more popular are the LARCs, which are long-acting reversible contraceptives. And they're actually recommended as first-line cycle control and contraception for women of all ages. And so this includes the hormonal implant for women placed in their arm. There are 2 hormonal IUDs, the Kylena and the Mirena, and the non-hormonal copper T. And interestingly, in Australia, only 5 to 10% of women use this because there's a lot of misconceptions about them as well. I'll talk about the Implanon first. I mean, it is a very effective little plastic rod which contains progesterone, and they can be used from adolescence till menopause. They last for 3 years. They actually don't, they don't cause that. There isn't a lot of pain getting it put in. They're very reliable. They're very reversible. They can be effective at controlling bleeding and can actually reduce the likelihood of ectopic pregnancy and pelvic inflammatory disease. There's a lot of myths about it migrating all over your body, but that is highly unlikely because there's a new method of delivery that's very safe and reliable. It doesn't affect your fertility. It rarely affects libido. So I guess that's a benefit compared to the pill. I guess on balance, we see clinically that perhaps it's not as effective as treating heavy bleeding and might be associated with mood effects like the pill. So I find more women are opting for an IUD. One of the most useful IUDs are the 2 hormonal IUDs. I think they've really helped women historically with heavy menstrual bleeding and pain, that's with or without endometriosis, irregular periods, menstrual migraines as part of HRT. They do not carry the same risk of thromboembolism that the pill does, and they're highly effective. They're probably the best we have. I mean, they're 99.8% effective. It's sort of a set and forget mode of contraception, which is so appealing to women, not having to remember to take a pill or, worry about if they've got their period. It's really saved a lot of women, I guess you'd agree, having a total hysterectomy, whereas a lot of young women would have had that previously just for management of their heavy periods. It's a myth, really, that young women and adolescents can't have IUDs, or women who haven't had children. The World Health Organization supports this recommendation in terms of safety. There's a lot of fear about having this idea of having a foreign body in your uterus and thinking it's a really big, and it's, women think they're going to feel it when they're walking around. The Kylena is about 28 by 30 millimeters, and the Mirena is slightly bigger at 32 by 32 millimeters. So they're very small. It's inserted in an office procedure, and it usually only takes about 10 to 15 minutes. I mean, it can be briefly uncomfortable, but, at the WOOM, we certainly do a lot to prevent the pain. And some women go on to have it, in some cases inserted in theatre with a short anaesthetic, but it's much less common. There's a lot of fear around infections and IUDs. The old copper IUDs were designed very differently to what they are now, and they were associated with pelvic infection. And so I guess this is where that myth came from. There is an increased risk of infection in the first 3 weeks after insertion of any IUD, but then it goes back to the background risk of someone without an IUD, and it really depends on how many partners you have. And particularly the progesterone IUDs like the Mirena and the Kylena act to change the cervical mucus. The progesterone does that, and that actually reduces the passage of infection into the pelvis. So it's actually kind of protective. And once again, people think, oh, I'm not having my period on this, so maybe something's wrong with my fertility. I don't want to have that form of contraception. But it's rapidly reversible, and it's very easy to remove an IUD or an implanon. And generally, once you remove these modalities, your cycle will return to normal. And I mean, that's another point to make, I guess. It's sometimes your baseline fertility is not what you think it is. Your cycle may not be what you think it is. And we often like to blame whatever we've been on. And often it's our age or hormonal related change that's actually taken place without us knowing. So
yeah, I love that. That's such a good point to make. So many people come in here and say, oh, the pill mucked up my cycle, or the IUDs affected something, and it's, you dive deep into the history.
Nice
I mean, it's easy.
And sometimes it is the case, and that's.
But it's always important to dive deep into the history and go, hang on a sec, your periods were quite irregular before you even started. So let's go back and see what else is going on.
Yeah. Yeah.
Wow, what an amazing summary. I'm just going to
keep talking. What?
Hey, let's move on to one other topic, which I know you are really passionate about, and I'm super excited about this. We've chatted a lot about the fact that a lot of women now really wear busy as a badge of honor. Hey, how you going? Oh, I'm really busy. I'm
guilty of it. I'm guilty of it. You're
totally. Hello.
Yeah.
I can speak to this one, but the world is busy, but there are a lot of women who have that rushing women syndrome, busy, juggling 1,000 things. And it does impact on their health. And so I am so excited that at WOOM, you and Michelle and all of our team are working on developing a package, a Well Women's Check. Do you want to talk to that a little bit?
Definitely. I mean, I'm very passionate. I said it before about helping busy women prioritize their health. We don't allow ourselves time to look after our health. It's always, last on the list. And then it's, I see women who they don't get to us until they're absolutely struggling. They've hit the wall, they're burnt out, and then they feel ashamed because they're not some kind of superhero, when they're iron deficient, anemic, flat, and they're dragging themselves in there. And it doesn't have to be like that. And I find that women now, with the change in pap smears and cervical screening, we used to go and get that done every 2 years, and you'd get some sort of checkup with your GP. But now it's every 5 years. So women don't come in for quite a long time. And, they put it, as I said, at the last of their list of things to do. And as GPs, I mean, Michelle will agree with me that we're really about preventative health. That is the ideal health model, really. And so that's why we came up with this Well Women's Check. And it's something that I think that women can come in and do amidst their busy schedules. Shouldn't really take longer than 45 minutes out of your day. It involves a thorough checkup, not just of gynae health, but, not just your cervical screening, your sexual health screening, but breast checks, weight, nutrition, bowel screening, cardiovascular risk, osteoporosis risk, skin, sleep, mental health. These things all interplay and are really, really important, and important to check in with your doctor as well on a regular basis. It's really lovely that at WOOM we have a multidisciplinary team, so we can treat women holistically. and alongside your primary GP as well, to make sure that, you know, women remain on top of the dynamic changes that are going on in their life. And I mean, we can do this at all ages as well. I think it's important. And I know the focus is going to be different at different ages, but I think a good interval would be every 2 years to be getting a well women's check done. And I think, you know, a lot of us have put our health on hold with COVID last year. I think it's time to sort of rein things in and get back to just making sure we're on top of general checks and, you know, being preventative about our health and proactive.
Yeah. And the fact that if you do create this set interval of, okay, it's in the diary and being recalled, like you would be recalled for cervical screening, you're recalled for your well woman's check. The one point that you brought up, which I think is really key, and particularly in the context of what we've been through and what we're going through with the pandemic, is the concept of that mental and emotional health, because I think that sort of physical, mental and emotional all, as you said, interplay together.
Yeah, definitely. I think we sometimes discount that as we absolutely burn out. So I think, you know, coming in and having a chat, we almost feel guilty for having that time for ourselves to talk about ourselves, but we should, you know, if we still manage to get our hair done or nails done or whatever, this is just as important. We need to prioritize it. Absolutely. It is.
Oh my God, that's so true. We all book in for our regular hairdo. And when we sit down with the hairdresser, it's like, okay, let's book in our next one, shall we? We'll book it in another 8 to 12 weeks. Let's get it in the diary.
Yep.
Why would you not be doing that with your well women check as well?
That's right. Yeah. Something definitely to be encouraged. And I think, you know, it will flow. I think this will flow, as I always say, like, I mean, women, you know, it flows to their friends, to their families, to their workplaces. If you're well, it will stabilize everything. So
definitely. Oh, I love that. Finishing on that holistic note, Sunita, yes. Thank you so much for joining us tonight. Is there any sort of last words of wisdom that you'd like to share with everybody?
Oh, not really, but I just look forward to seeing everybody at the WOOM. I hope that people come and visit us, and, you know, we have the time to listen to women, to really hear what you're saying, and it's a very individual thing. You know, we tailor your treatment, your care individually. So, and, you know, that's what we're there for. So
beautiful words. I love it. Dr. Sunita Chelvanayagam.
Well pronounced.
I nailed it. Have a beautiful night. Thank you, everybody, for listening, and we'll see you soon.
See you later. Thanks.